Thank you so much for the very kind introduction. So, hi everyone, I'm Cecile, and today I'm going to tell you a little bit about the impact of sleep restriction on autonomic control of cardiovascular function. As usual, we start with a quick background. So, a little bit about me. I come from a very small country called Lebanon on the shore of the Mediterranean Sea. As you can see in the picture here. And those who have taken classes with me know how much I preach about the Mediterranean diet. So now you know why. This is also because my hometown is very famous for olive trees and olive oil production. That picture over there. And fun fact about Lebanon, you could be swimming in the Mediterranean in the morning and skiing in the mountain in the afternoon because it's so small. You can just drive through the whole area. So I grew up there my whole life. My parents are a cardiologist and a psychologist, so I grew up really appreciating the importance of health, but I also knew for sure that I did not want to be a physician. So I wanted to be in that field. And during orientation, I really fell in love with nutrition. It was relatively new at the time, and I found it so interesting the power of food, the power of prevention, which could even be better than treatment sometimes. So I completed my bachelor's in nutrition and dietetics. I then went on to do my dietetic internship, which is basically an internship at a hospital for a year where you get exposed to all the areas of nutrition. So, as you can see, community nutrition, being in the kitchen, seeing the whole processing, food safety side, also working at the hospital, seeing patients, which was my favorite part. Patient interactions were the most rewarding to me, and seeing really the outcomes, the improvement, and the change in quality of life was very rewarding. I then went on to pursue a master's in human nutrition at the American University of Beirut, where I worked mostly on the metabolic syndrome. And after I graduated, I stayed there for 2 years as a research assistant. Dr. Faris, my mentor at the time, had just joined the university and he started his lab, the Nutrition Metabolic Research Lab. And I was the first and only research assistant there. Our work was mostly related to sports nutrition. So we worked with athletes, student athletes, athletes with injuries, also worked a little bit on childhood physical activity. And interestingly, this was the first lab in the whole region to tackle the area of exercise physiology. So when we did a VO2 max test, it was the first one in the whole region. So I remember they sent this on the university newsletter. It's now a very nice memory to me. They've came a long way since then, but at the time, this was really something new. So it was really a privilege to learn all of this from him and establish this whole program together. After that time, I got married and I moved to the United States in 2021. First stop was Rochester, Minnesota. So the snow was a great shock to me. Uh, I've seen it, of course, but not this much. And interestingly, within 2 weeks of being in the US only, I was still overcoming my jet lag. I came on a trip to Columbia, Missouri, because my husband was interviewing at the hospital. And they were so kind. They put me in a little golf cart and they gave me a tour of the campus. And all I could think about was, where's Gwen Hall? Because I had done my research and I knew about the NEP program and I found it so great. I was so interested. So I emailed Ben at the time, the old Darius, and I told him, like, I'm interested. Who can I talk to? And nice coincidence, Dr. Limberg was the director at the time. So I set up a meeting with her, and it quickly felt like a perfect match. I was so interested in her area of research, in her lab, and she gave me a whole tour of Gwen and Mickey, and I just knew this was the right place for me. It combined my two favorite areas, nutrition and exercise, and I could see how strong the program really is. But this wasn't enough. She was so kind that she actually linked me to her previous lab back in Minnesota. So I went back to Minnesota with a job. I joined the Joiner Lab at the Mayo Clinic, the Human Integrative Physiology and Clinical Pharmacology Lab, and it was a great time. It was my first introduction to real integrative physiology. I learned so much from leaders in the field. It was really super, super interesting learning experience. And it was a great preparation for working at the Limburg lab because it's at that same level, really. So that was a very, very great learning experience for me. Following year, I moved to Missouri. I was supposed to join the PhD program right away, but my beautiful daughter came along. Nice surprise. So I joined in 2023 with a study buddy who did steal my biochem notes one time. I'm still not over that, but anyways, 2023, I joined the Limburg lab, and ever since, I've been an active member of the lab, learning so much, learning research techniques, presenting our work, and it's been great. I'm learning so much, and I'm excited for next steps now, starting my own research as well. During that time, as Dr. Limburg mentioned, I worked on two of my other interests. So I pursued a graduate certificate in public health just because the dietitian in me wants to know how can I translate my research findings to the population level? How can I benefit patients? So this was very helpful as well and a great addition. I've also been learning so much from Dr. Eifert. Thank you for coming today. From her expertise in teaching, I've been lecturing in her classes a few times, but also learning all the behind the scenes of teaching, which has been amazing. So I'm very grateful. Now we can get started. So we're going to start talking about sleep, and shout out to Dr. Canali. I hope she's feeling better. My very first semester here, I took a topics class with her, which was about sleep, and it really sparked my interest in this topic and played a big role in my research interest right now. So a little bit about sleep. Sleep is an indispensable element of human biology. It really affects our metabolic, cognitive, and cardiovascular function, and it has been recently recognized, specifically in 2022, when the American Heart Association added sleep to its cardiovascular health construct. So now sleep has joined other factors like smoking, diet, exercise to calculate a cardiovascular health score. It used to be Life's Essential 7, and now it's Life's Essential 8. So this is great recognition. It's also an objective of Healthy People 2030. But when talking about sleep, it's important to acknowledge that it's very complex. It's a multidimensional construct of many factors like sleep continuity, satisfaction, regularity, and duration, which will be the focus of my talk today. Sleep duration is defined as the total sleep time between sleep onset and offset, usually calculated either per night or per 24 hours. And current guidelines recommend that adults obtain a minimum of 7 hours of sleep per night for optimal health. Unfortunately, due to technology, our modern lifestyle, we don't really meet this recommendation. Sleep duration continues to decline in the past 50 years, and right now, 1/3 of the US population does not meet this guideline. This is equivalent to 80 million adults. And so many populations are affected by this, are vulnerable, specifically shift workers who compose a big part of the US workforce. And why is this important? Looking at the social ecological model of sleep health, if we take a step back and look at the bigger picture, our sleep behaviors are highly influenced by larger constructs, things like globalization, where we live, where we work, our income. But also, at the end of the day, it's a behavior and it's a choice, which makes it very valuable for us to study and hopefully later on create interventions because we can easily affect the lifespan and the health, specifically cardiovascular health, which is my topic today. So in research, we can assess sleep in different ways. We have subjective methods like sleep diaries or sleep questionnaires, and more accurate measures which are more objective, like watches, sensors, or polysomnography, which is the gold standard. It basically gets inputs from brain activity, eye movements, body temperature, combines them all to give an accurate idea of sleep architecture, duration, all of that. And some studies even use a mixed model of both for added accuracy. Now that we've covered that, let's see what's the link with cardiovascular health. So sleep has been shown, and there's plenty of epidemiological finding showing that it's linked to coronary artery disease, the metabolic syndrome, both all-cause and cardiovascular mortality, and hypertension, which is my focus today. Individuals who are sleep deprived were shown to have a twofold increased risk of developing hypertension, with a very close link between the two that is even dose dependent. So looking at our map, we can see that short sleep duration is very prevalent in the US with a specific geographical distribution that is very similar to cardiovascular disease, very similar to hypertension. So there's really an overlap between these three distributions, and we can see more and more that these problems are linked together. And wherever people are sleeping less, there's more cardiovascular disease. So great opportunity for us to tackle. Quick spotlight on what I've talked about at CV Day. Those who were there, I'm sorry, but it'll be super quick. It has been speculated that the association between sleep restriction and hypertension and cardiovascular disease may be mediated by arterial stiffness. And we know it is a major risk factor for cardiovascular disease. So in this study, it was an inpatient protocol where patients stayed in the hospital throughout this whole time, 4 days of acclimation, 9 days of either control sleep or sleep restriction, followed by recovery. Sleep was monitored using polysomnography, and blood pressure was monitored using an upper arm cuff, and carotid femoral pulse wave velocity was calculated, which is our measure of arterial stiffness. It's calculated by measuring the distance between the carotid and the femoral arteries divided by the time of the delay of that pressure waveform. And results were so interesting. We can see pulse wave velocity remained the same after control sleep, but increased significantly after sleep restriction, really showing that we have stiffer arteries. This was also strengthened by two additional findings, which were a shorter round trip time and a shorter carotid femoral mean time. So we have stiffer arteries. These pulse waves are traveling much faster and coming back sooner to the heart, really showing the detrimental effects of short sleep. But our focus today will be more on the autonomic nervous system, which I will spend the rest of the talk talking about. So among the potential mechanisms behind the abnormalities that happen in sleep restriction, autonomic impairment is a major one. And it's important because it's the primary neural regulator of our cardiovascular function. So it's basically how our nervous system regulates our cardiovascular function. And its main job is to keep our body at a state of homeostasis at all times, at rest, and in response to stress. So it looks something like this. Our autonomic nervous system is composed of two branches, the parasympathetic and the sympathetic branch. Our parasympathetic branch dominates more when we're at a state of rest. Right now, you guys are relaxed. It dominates more. It's also known as rest and digest. Meanwhile, our sympathetic nervous system kicks in when we're in a state of stress. That's why it's called your fight or flight response. So that homeostasis is basically a dynamic, flexible balance between these two branches. It's not that we want them to be equal, but we want the right one to kick in when it's needed. And luckily, we can measure their activities at the lab. So parasympathetic activities usually measured using vagus nerve recordings. These are more established in animal models. In humans, just getting started. So we rely more on non-invasive measures such as heart rate variability. And when it's high, it shows that that sympathetic side is dominating more. And to measure the sympathetic activity on its own, we also have some methods. We can either measure norepinephrine in the blood or in the urine, and this was more the traditional way of doing it. Now, luckily, we have microneurography or muscle sympathetic nervous system activity, which we do at the lab, and it's an accurate measure of sympathetic nervous activity. You can directly see it continuously in real time, which is great. So why is this important? As I said, our nervous system is regulating our blood pressure. Blood pressure is highly neurogenic, and every time a sympathetic burst fires, neurotransmitters are released. They bind to adrenergic receptors on the blood vessel walls, leading to vasoconstriction and eventually increasing our blood pressure levels. And this has been studied in the literature for a very long time. Ever since I think the first enhanced cohort in the 80s, they started noticing that there's a link between sleep and hypertension. These are some of the few landmark studies that gave us the idea to start researching this in the lab in more experimental studies. So they did establish that short sleep is linked to hypertension, but what is the mechanism? So now I'm going to tell you a little bit about mechanistic hints that we are seeing in studies. One very interesting study was conducted in Japan. They noticed a phenomenon called karoshi, where technical workers working overtime, exhausted, not sleeping, were suddenly crashing, even dying. So they decided to monitor that. They created a recorder, a portable recorder that measures blood pressure, physical activity, temperature, EKG, and they just followed these workers, either on a normal night or on a night where they were working overtime, almost sleeping 3 hours only. And they noticed in that top line, you have those who weren't sleeping enough. And you can see that their systolic and their diastolic blood pressures increased significantly throughout the whole day. So that was interesting. And this was coupled with higher norepinephrine and higher heart rate variability. And just as I told you a little bit ago, this really shows that we have the sympathetic side of our autonomic nervous system dominating. So this was a finding showing sympathetic predominance in sleep restriction. Following this, two landmark studies were done, sleep deprivation studies though. The first one was a night of total sleep deprivation or normal sleep. And they noticed, contrary to everything I just said, that blood pressure was high, but MSNA was low. So this really contraindicated everything we know so far. There were no changes in heart rate, no changes in plasma catecholamines, basically implying that the pressure response of short sleep is not mediated by the sympathetic nervous system. Another similar protocol implied that there must be a compensatory mechanism. So there's an alternative mechanism playing a role here, which turned out to be our baroreflex. So in this study, similarly, it was a 24-hour sleep deprivation study. They noticed that diastolic blood pressure was high, but MSNA was low. And they pointed at the baroreflex as that underlying mechanism, which is basically our baroreceptors, which are receptors embedded in the carotid sinus that once blood pressure is high, they sense a change in stretch, they act in right away to restore it back. And with time, as blood pressure is higher, they start getting used to that high blood pressure. They start treating it as the new normal. So they don't act right away. They act at a higher blood pressure, which we also call that threshold blood pressure or baroreflex set point. So an interesting factor that we can now add to that picture, and now we can know that this dynamic balance also receives feedback from our baroreceptors that can play a role in changing the contribution of these branches. So looking at how this affects our blood pressure. So blood pressure is our controlled variable, our variable of interest. Once it's high, this is directly sensed by our baroreceptors, which send an input to our central nervous system saying, hey, we need to bring blood pressure back down. It influences our sympathetic and vagus or parasympathetic branch, affecting stroke volume, heart rate, resistance vessel tone, ultimately affecting cardiac output, CPR, in order to restore blood pressure back to normal. So now that I've told you that the autonomic nervous system plays a huge role in regulating our blood pressure, we can bring sleep back into the picture. So sleep restriction and blood pressure. Everything I told you so far, you may have noticed I've been using the word deprivation. This is because at the time, all the available studies were sleep deprivation, 24 hours of no sleep. Who stays awake for 24 hours? Not realistic. So I'm more interested in things that are more realistic. So the low-grade cumulative effect of sleep loss that many of us experience, this is more of a sleep restriction model, which is not very common in the literature, not very studied. What we know is a little bit limited, so I'm going to summarize to you now the available literature on the topic. So one study among night shift workers, they had acute sleep loss, so sleeping less than 3 hours per night for a whole week. We can see that their systolic blood pressure increases significantly at day 7. Similarly, their mean arterial pressure increased significantly at day 7, really showing that blood pressure is increasing. In a study in premenopausal women, they reduced their sleep modestly, 1.5 hours per night for 6 weeks. We did see increased blood pressure throughout the whole week. You can see in that first graph, systolic blood pressure is really high, specifically towards the end. Additionally, their wake diastolic blood pressure and their wake mean arterial pressure in the morning was higher as well. So really, blood pressure is being affected throughout the whole day. In another study in healthy adults, they had an interesting protocol. This was a 22-day in-hospital protocol. It was basically repeated sleep restriction of 4 hours per night. They repeated it 4 times, separated by blocks of recovery in between. So you might think the recovery will solve the issue. It didn't. So you'll see now systolic blood pressure was higher in that first block of sleep restriction. Diastolic blood pressure was higher in 3 blocks. And interestingly, blood pressure dipping, which usually happens at night while we're asleep, was impaired. So really now we can say that it affects blood pressure in the morning, throughout the day, throughout the night. So it really has a big effect. This study on healthy men really also showed something similar. The protocol looked like this. There was a baseline, followed by sleep restriction, followed by a recovery period. Similarly here, systolic blood pressure increased, and if you can see towards the end, that's the recovery period, and it just keeps going up. So even when these individuals went back to sleeping normally, systolic pressure kept going up. Similarly for heart rate. Oops, sorry. Similarly for heart rate. So this was a great finding that catch-up sleep is not enough. And if you think about it, this really mimics our work week. So if you work all week, you're sleep restricted, and you think, I'm going to sleep in on the weekend and everything will get better. Doesn't. So it really has a strong effect, and catch-up sleep is not enough. In this study in young adults, it was a 16-day inpatient protocol, very interesting. 4 days of acclimation, 9 days of either sleep restriction or control sleep, followed by recovery and a crossover design. Patients stayed in a hospital the whole time, and again, higher blood pressures, higher systolic blood pressure during sleep, which was interesting, and higher norepinephrine. Finally, everything I've told you about now you can see here. So really showing that we have higher sympathetic activity in sleep restriction. Really interesting. What about the baroreflex? So I read this paper and I was like one more answer I wanted to know. I wish they studied that last factor. Why didn't they? After doing some digging, this study was done at St. Mary's Hospital, the Mayo Clinic campus, by Dr. Kovassin and Dr. Somers in cardiology. And I found out there was one more person with them this whole time. So Dr. Limberg was actually a collaborator on that study, and it turned out to be a part of a bigger study with so many outcomes, including MSNA, which she did herself, and no one knew. It's not analyzed ever since. So luckily, she was able to give me access to this data because it would answer all of my questions, and I'm now analyzing it. So I'm going to tell you a little bit more about this protocol. First, I'm going to tell you about my first aim, which is to assess the impact of sleep restriction on resting MSNA, this marker of sympathetic nervous system activity, and baroreflex sensitivity, which is basically the slope between MSNA and blood pressure. And it shows how well that baroreflex is working among healthy subjects following experimental sleep restriction. with the hypothesis that it will be higher, MSNA will be higher, baroreflex sensitivity will be lower, indicating that there's an autonomic imbalance. So they recruited healthy young men and women aged 18 to 40, BMIs 18.5 to 35, non-smokers, no diseases, no sleep disturbances, and any pregnant women, night shift workers, or those with tobacco, alcohol, caffeine intake were excluded. It was all done at the Mayo Clinic Research Unit. They stayed there during this whole time, and all kinds of research techniques were done, so many valuable data. Um, the way they did sleep restriction here was strategic because they cut sleep from the beginning and from the end. So participants slept later and woke up earlier in a way to preserve the midpoint of sleep. That way, we're really focusing on duration only. So we're not messing with the circadian rhythm. Sleep was monitored using polysomnography, and diets were controlled. So participants were consuming a weight maintenance diet throughout this whole time. So the part of the protocol that would answer my question, participants came for instrumentation around 3 hours after a meal. They were in a supine position, and the first measure was MSNA, which I mentioned a few times so far. This is done by locating the nerve posterior to the fibular head, and we use ultrasound to locate it. Once the nerve is found, a recording electrode is inserted in the skin, kind of like an acupuncture needle, so nothing very extreme, with a reference electrode as well. Once you find that, you can actually see and hear the nervous system activity, the sympathetic nervous system activity, which looks something like that. So that's recorded while we have blood pressure at the same time. So we get an idea of baroreflex sensitivity as well. This was followed by a head-up tilt test, which also gives us an idea about the baroreflex activity. It's basically a test where participants lie down for 5 minutes. Then that table is tilted to 60 degrees for 5 minutes. Then they're tilted back for an additional 5 minutes. And this really challenges the baroreflex to see how well it can bring things back to normal. Another added component. So it has been shown that if at rest we don't see anything, a stressor, a physiological stressor, might induce a response. So sleep-related sympathetic and cardiovascular responses may become more pronounced or more exaggerated once they're faced with a physiological stressor. And interestingly, some studies show that the response to that stressor can predict hypertension risk in the future. So they followed participants and really saw that the way you respond to these stressors is a predictor of hypertension risk. However, we don't have studies in sleep restriction. So this was also a wonderful opportunity to look at that. So a little bit of data from what's available. So there's this study on sleep reactivity. Sleep reactivity is basically a score calculated from questionnaires. Basically shows how predisposed you are to having sleep disturbances. So they divided individuals to low sleep reactivity and high sleep reactivity. And they faced them with a stress test. And they noticed over there, you can see the high sleep reactivity group in the black dots had a much higher heart rate response to that stressor. So again, this proves what I just said about the stressor being able to exacerbate a response. And this is only people who are more prone to having sleep disturbances. This study in 55 postmenopausal women showed that MSNA reactivity increased more rapidly in the first 30 seconds of a cold pressor test in women who have sleep disturbances. You can see in the red box over there, this is the women with sleep disturbances. And once they did a cold pressor test, which is basically submerging the arm or the leg in ice to exacerbate a sympathetic nervous system response, women with sleep disturbances had a more pronounced reaction. So again, there is a link between sleep, stress, and blood pressure. This study from our lab followed individuals to record their habitual sleep duration. So no intervention on their sleep They just recorded how they normally sleep. And then they came in and they did a cold pressor test again. And although habitual sleep was not associated with MSNA or blood pressure at rest, uh, the association emerged more with CPT. So, looking here at habitual sleep, there is a strong inverse relationship with MSNA burst frequency, diastolic blood pressure, and mean blood pressure. So this brings us to aim 2, which is to look at the response to stress and see how sympathetic and cardiovascular reactivity would be among these subjects undergoing experimental sleep restriction, with the hypothesis that the stressors will produce a more pronounced response. So again, instrumentation, this time there's a stressors. So first, mental stress. It's 2 minutes of quiet rest, followed by 5 minutes of a math test. That's pretty stressful. Then a Stroop color word test, just a test of different combinations of words and colors that gets you a little bit confused. During that time, there's venous occlusion plethysmography, or VOP, which is basically an upper arm cuff being inflated cyclically and a wrist cuff inflated to exclude the hand from the circulation. So we basically know what is going on. In the forearm, we get a measure of forearm blood flow, followed by 5 minutes of recovery and a survey. Second stressor, which I've mentioned a couple of times so far, is the cold pressor test. So 2 minutes of quiet rest, 3 minutes of hand in the ice water, 2 minutes of recovery. There we go. Okay. Last part of my talk. It won't be long, but you know, the dietitian in me has to talk about obesity. So this is the last point that I'm really interested in looking at. So there's a strong link between short sleep and obesity. Short sleepers have higher BMIs, higher waist circumference, and we know that abdominal obesity is detrimental. So this is really interesting. 16% higher prevalence of obesity and 9% higher prevalence of abdominal obesity. And looking at that yellow line on top, it's the individuals with obesity who are the poor sleepers, and this was followed over time. Okay. So in this study, this was an inpatient study. Participants underwent sleep restriction for 4 hours or control 9 hours of sleep. Very interesting findings. They gained weight, but they gained visceral fat in particular, and this was seen on CT scans. So this was first of its kind because they were able to get this accurate measure of visceral obesity. We can see that both subcutaneous and visceral fat increased and expanded. But interestingly, in that graph, you can see in red the visceral fat in those with sleep restriction increased very early on and continued to increase up to recovery. So even in recovery, it's still going up. So this was very interesting. And the culprit, increased energy intake. So these participants were eating more. It was an average of almost 300 calories extra per day, mostly from calories, from protein, from fat, from carbs. So it's this positive energy balance that's behind this hyperphagia, this weight gain that's happening in sleep restriction. And they were mostly consuming sugary snacks, processed foods, high sodium foods. So it wasn't really a good quality. Interestingly, it was coupled with no change in energy expenditure, no change in appetite hormones. Now, this was in a hospital, so it's not very surprising that energy expenditure didn't change. In this protocol, participants had the freedom to leave, come back, go out, and it was more in a free living condition. They ate more fat, specifically saturated fat, um, and no change in energy expenditure. So they had the opportunity and they didn't move more. So not only are they changing their nutrition habits, their intakes, their preferences, they're also not moving. So sleep restriction in itself is obesogenic. It's promoting all of that negative behavior that we don't want. Um, Looking here, this could explain part of it. So we're awake for longer, we have more opportunity to eat more, which makes sense. We're tired, we're moving less, which also makes sense. But there's also some hedonic factor because they're craving that processed food, that really unhealthy um, snacks. So that's interesting too. No changes in hormones in that study, but we can see that there is a relationship here. And I found this super interesting. So in this study, they wanted to see the impact of sleep on hypertension. So in that first section, in healthy individuals, if you look at that teal bar, those who had poor sleep, who weren't sleeping well, had the highest hazard ratio of hypertension, which is expected after everything I told you so far. But once they had unhealthy habits, so once we move more towards that poor section, which means worse diet quality, BMI, physical activity, and smoking, you can see that that hazard ratio of hypertension just tripled, become much worse. So lifestyle has a big effect. Even if you're sleep restricted, lifestyle can either worsen or maybe just mitigate this effect. So what happens in obesity? This is my next question, and this is what I want to know, which which brings me to my next question. In individuals with obesity who are sleep restricted, what is the difference? So, luckily, that protocol I've been telling you about has an additional cohort which was eating whatever they wanted. So, again, perfect coincidence to answer this question. So, I wanted to see same outcomes as before, but what if it was in the setting of ad libitum food intake? What if they could eat whatever they wanted? What happens? So, I hypothesize that the response to stress will be more pronounced. Similar protocol, I won't repeat it again, but the only difference is that they had unlimited access to food. So they had access to the cafeteria, to outside. They had a basket filled with snacks in their rooms. So they could really eat whatever they wanted. And it was a great opportunity to see how the behavior will change this time. Being analyzed, so stay tuned to see the results. But my next step, if I analyze all of this, would be hopefully to enhance our mechanistic understanding of autonomic control of cardiovascular function and sleep restriction, and uncover how unlimited access to food or obesity would really change this relationship. Which brings me to my next step. So, currently analyzing all of this. So, hopefully, I'll have some answers soon. Additionally, I have my study IRB approved to examine the effects of obesity on blood pressure reactivity following sleep restriction, but it's more of an acute model. So it's a week of sleep monitoring at home. You would just wear a watch, followed by 1 night of normal sleep, and then one visit, 1 night of sleep restriction, and another visit. And I would have a group with normal weight and a group with obesity, and see if this changes in the setting of obesity. We did our first pilot study last week. Matt was kind enough to I thought I'd make you guys laugh towards the end. Matt was kind enough to volunteer to be our dummy for the pilot. He's still alive, he's here in the audience. So we're recruiting now, recruiting time controls. If you're interested, email the Limburg Lab or check mustudies.com. There's a survey, and you can know right away if you're eligible. Thank you. Thank you. Usually in these studies, individuals with sleep disturbances are excluded. Yeah. It- there's like a whole other world of sleep apnea. I'm sure if I looked more into that, I would be able to answer your question. But in these studies, it's more healthy individuals with no other issues. Thank you. I don't think it would compensate because if I go back, you can see that even the healthy individuals have a higher hazard ratio of hypertension. But unfortunately, that bad lifestyle will make it much worse. Yeah, I think of it more of like a holistic sleep well, eat well, exercise. There's not like one answer. Mhm. Almost there. Sorry. Okay, here we are. Yeah. Got better. Yeah. 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 Yep. 9 hours. Mm-hmm. Yeah. Hmm. Now, duration is the most studied epidemiologically, maybe because it's also easier to assess, and there is a significant link. So that's why, but it's also a world of its own. If Dr. Canali was here, she would tell us about circadian misalignment, sleep architecture. So each one plays an important role. I'm sure deep sleep, those stages of sleep are important as well. But from what we're seeing in the literature, duration alone has a link. So it's interesting. Yeah. Yes, thank you. There is a diet log, like a diary. So they document their food, and there's like a little reference for portions with that, in addition to a sleep log as well. Thank you. Thank you.